Welcome to my channel. I'll be talking about Risperidone today. There's a red light, and when you have red light, you know the meaning, right? Don't go. Stop. Never try Risperidone in Lewy body dementia. If there's an elderly patient with dementia and psychosis, please involve your psychiatrist. Low dose is expected here. The maximum daily dose mostly is 6 milligrams. And why that? We are using this medication because we are fed up with first generation antipsychotics, right? Extrapyramidal side effects and relative malignant syndrome. Once you use risperidone at a very high dose, then you are not covering for the deficiencies of the atypical. You will teach the patient to extrapyramidal side effects and probably neuroleptic malignant syndrome. So, risperidone, low dose. If you use a daily dose above 8 milligrams, what will happen? Just what I've said. The patient will come down with extrapyramidal side effects and sometimes with neuroleptic malignant syndrome. In other words, higher dose of risperidone will do no good anymore, will actually present with severe side effects as if you are using the typical antipsychotics. Risperidone could appear under different brand names like Risperdal, Risperdal Consta, Pervasive, Risperdal M-Tab, Risperidone M-Tab, ACT Risperidone, AG Risperidone, Apple Risperidone, or Teva Risperidone, depending on where you are and what is available. Belongs to the class of medications known as antipsychotics, atypical antipsychotics or second-generation antipsychotics, and also classified as antimanic agent. When you want to discontinue this medication, please don't do cold turkey. Decrease the dose gradually, or else you will run into withdrawal symptoms. The withdrawal symptoms here listed will be insomnia, headache, nausea, vomiting, and diarrhea. So, taper off for weeks. And if the patient is on this medication for a long period of time and you want to take it off, then you have to taper off for months. It depends on how long and the dosage this patient is on. When you want to switch from one antipsychotic to the other and risperidone is involved, while switching, please gradually discontinue the first agent. At the same time, start the newer agent with a low dose and gradually increase. When and where can we use risperidone? In autistic child with irritability or aggression, you can use risperidone. In bipolar mania, in delirium, in conduct disorder or oppositional deviant disorder, pervasive developmental disorder, and schizophrenia. The list goes on to include Tourette syndrome, substance intoxication, tics, Huntington disease, delusional disorder, obsessive compulsive disorder, and even in unipolar major depressive disorder. Risperidone can appear in various forms. In form of prefilled syringe for subcutaneous injection. In that case, you're going to find series available for that purpose at 90 milligrams or 120 milligrams. And it could also appear in form of solution for oral usage, like Risperdal 1 milligram per ml or generic 1 milligram per ml. That's not enough, or that's not the end of the list. Risperidone extended release suspension is available to be reconstituted, and that will be given as intramuscular injection. And in that case, you're going to find Risperidone constant at 12.5 milligram, 25 milligram, 37.5 milligram, or 50 milligram. Then you can have tablet per aura as Risperidone 0.25 up to 4 milligram. And you can also find tablet per aura as generic different strengths, just like Risperidone 0.25 to 4 milligram. There is tablet disintegrating for oral use. In that case, you're going to find Risperidone M-tab from 0.5 milligram to 4 milligram, or Risperidone M-tab from 0.5 milligram to 4 milligram, or generic from 0.25 milligram up to 4 milligram. Now, administration. You can give this medication with or without food. The oral solution can be given directly, or you mix it with water, with coffee, orange juice, milk, but never mix it with cola or tea. The disintegrating tablet should be placed on the tongue. No chewing, but you swallow after it has dissolved. In intramuscular injection, please shake that container very well before withdrawing and administering it. Never give this medication intravenously. Please, no IV here. You give subcute into the abdomen. For long-acting intramuscular injection, that will be applicable in the phase of bipolar disorder, in schizophrenia treatment, and as monotherapy for acute mania. You can add this medication to lithium or valproate. And in autistic child with aggression, you can place the child on the long-acting intramuscular injection. But in all these cases, have that meaningful conversation with your psychiatrist, please. Adverse reactions. Hyperprolactinemia, particularly in women of childbearing age. Let them know that there could be hyperprolactinemia. And you know what that means to a woman of childbearing age, right? There might be infertility from irregular menses, increased appetite, nausea, vomiting, diarrhea, and of course, extrapyramidal side effects. If you have followed this presentation from the onset, I've said if you use Risperidone very high dose, above 8 milligram per day per aura, then you may run into extrapyramidal side effects or neuroleptic malignant syndrome. In that case, there could be acute dystonia, akathisia, Parkinsonism, or tardive dyskinesia. Other side effects could include insomnia, dizziness, drooling, tremor, urinary incontinence, or drowsiness. Still on adverse reaction, there could be nasopharyngitis, cough, rhinorrhea, fever, and arrhythmia. Prolonged QT. I have to explain here. When there is prolonged QT, if it's not handled in any way, the electrolytes is not controlled, medication treating it to prolong QT is not handled, or is genetic in origin, then there might be torsade point. From torsade point to monomorphic ventricular tachycardia, and that could go downhill to polymorphic ventricular tachycardia. If it's not corrected on time, polymorphic ventricular tachycardia could become ventricular fibrillation. Without defibrillation, polymorphic ventricular fibrillation can then become asystole. without advanced guide-like support being instituted, calling code blue within few minutes, the patient might give up the ghost and end up in the morgue. There's likelihood of facial edema and, of course, hypotension. You could see that I burdened some of these things: arrhythmia, prolonged QT, and hypotension. All these situations could kill the patient even while you are trying to help them. Orthostatic hypotension, palpitation, skin rash, eczema, pruritus, xeroderma, acne vulgaris, amenorrhea or irregular menses. Decrease high density lipoprotein and increase total cholesterol. You could see that I burdened that, right? Because we need more of the good cholesterol, that is high density lipoprotein. But in this case, it's going to drop. And the total cholesterol will increase, meaning more harm will be done. Decrease libido to those who are still active. Increase glucose. We have to take note of that in diabetic patients. Increase triglycerides, increase TGT, and increase dysfunctional uterine bleeding and anemia. Also, I will not forget temperature dysregulation. As a matter of fact, we advise patients on this medication to watch out for that. Contraindication. If there is hypersensitivity to risperidone or any components of the formulation, don't give it again, and don't give it now. Watch out. If there is arrhythmia or prolonged QT on EKG before administering this medication, then keep risperidone off the table. Anyone known to have been diagnosed with seizure disorder, please no risperidone. One, we just have to be careful so that in a bid to help that patient, we are not sending him or her to his or early grave. Remember arrhythmia and prolonged QT. So it will be wise to have EKG done if this patient will be on this medication for a long time. Let's have that done now. Okay, then anticholinergic effects. It's not that it's completely ruled out here, but it's pretty low when we compare risperidone to other neuroleptics. It has strong anti-emetic effects. That might be an advantage, right? Okay. Now, leukopenia and neutropenia. Okay. Here is a scenario. Someone is in an oncological ward, and then he or she is down with psychosis or mania, and you want to help, and you grab your risperidone. Be careful. If this is a patient battling with neutropenia before, and you are jabbing him or her with this medication for a long time, then you are not helping. You're actually causing more harm. And agranulocytosis, particularly when we have certain oncological anomalies, or patient is on another type of medication that could give agranulocytosis, please, let's be careful. Increased risk of transient ischemic attack and stroke. Let's watch out. Still part of the warning is CNS depression. So we have to advise on this medication because there's likelihood of sedation, although very low, but then it could happen. So driving, operating machines while on this medication is not advisable. Dyslipidemia, because we came across high density lipoprotein that will be down, triglyceride will be up, total cholesterol will be up, so it's not good for fat. It's going to give dyslipidemia. Esophageal dysmotility, aspiration pneumonia. Tardive is worse in females and elderly, and of course extrapyramidal side effects, particularly when we give this medication for a long time and on a very high dose. Still on warnings, there is likelihood of increased falls in anyone taking this medication, particularly in elderly, and we know the implication of that. We don't want anybody to fall, but when elderly people fall with osteoporotic bones, you know what that means. Hyperglycemia in anyone that is diabetic, you know the implication. Increased prolactin in a woman of childbearing age, hypersensitivity means we don't use it now. Floppy Iris syndrome intraoperatively, because when somebody is on risperidone and is now wheeled to operating room, and then you are checking the ocular reactions and everything, note this before making any determination to change your course of treatment. Neuroleptic malignant syndrome, temperature dysregulation, priapism, major depressive disorder. If that is the diagnosis on account of which we are using this medication, then watch out for the probability of increased suicide. So we have to put them under watch. Okay, keep an eye. Advise family members, particularly if this is a young person, right? Adolescent or young adult. There might be weight gain. Of course, we've been talking about dyslipidemia all this while. Okay, increased death in elderly with dementia, particularly Lewy body or with psychosis. Please involve your psychiatrist. Please be cautious in the face of hepatic and renal impairment. Drug-drug interaction. I will leave that to your pharmacist, your clinical pharmacologist, and better still to your psychiatrist to make that determination, please. Now, monitoring. I will not go over exact parameters to be monitored. You can come to my channel, check out my presentation on haloperidol, or you call it Adol. Then the monitoring under Adol is the same right here. So come back to my channel and check Adol presentation, please. Mechanism of action. There's high affinity for 5-HT2 and dopamine T2 with receptor antagonistic effect. The antagonistic effect at AV1 and AV2 adrenergic histaminergic receptors is active, but there's low affinity for 5-H10, 5-HTID, 5-HTIA receptors. Low affinity. There is weak affinity for D1, zero affinity for muscarinic receptors, low affinity for B1 and B2 adrenergic receptors. Examples of situations where and when we can use risperidone will be the following. Agitation. You can use risperidone 1 milligram. Repeat that every 2 hours, but the maximum dose you can give is 6 milligrams. In dementia, with aggression, you don't jump to use risperidone, but if the individual with dementia having aggression is having a very severe one, or you've tried some other stuff, it's not working, or it's refractory to other medications, in conjunction with your psychiatrist, which means I want you to discuss with your psychiatrist, with your pharmacist, then you can try risperidone in them. But please, mark my word, discuss with your psychiatrist, discuss with your pharmacist. And even then, you go for a low dose, as low as 0.25 milligram to 0.5 milligram per day. But even if you are permitted to use it, please, the maximum dose you can give is 6 milligrams per day. And why? I've explained earlier. Risperidone is pretty helpful, but when you give it at a very high dose, then you are going to have extrapyramidal side effects or neuroleptic malignant syndrome, as if you are using typical antipsychotics like haloperidol or chlorpromazine. And when you give this at all in dementia with aggression, even with the advice of your psychiatrist or pharmacist, please use it for a short period of time. We don't encourage these medications in elderly with dementia. Try for 4 weeks will be fine enough and taper off after 4 weeks. But once the diagnosis of Lewy body's dementia is made, never use risperidone. And finally, if you are using risperidone in bipolar disorder, that is acute mania or acute Antimanic phase, it is suspected to be used for maintenance therapy alone. You can give this medication intramuscularly as extended release suspension, and you can give 25 mg intramuscularly every 2 weeks. You can increase by 12.5 mg every 4 weeks. The maximum dose you can give is 50 mg every 2 weeks. And again, let me reiterate here. Contact your pharmacist, contact your psychiatrist. Risperidone is a pretty good medication, but you can do more harm than good if you don't put all these things into consideration. Thanks for listening. Remember to share this very presentation. Remember to subscribe to my channel. I appreciate it.